into some really compelling evidence for a higher 7.2 milligram dose of semaglutide for obesity management. We're going to break down the pivotal step-up trial, and we're focusing specifically on the data for patients with obesity who do not have type 2 diabetes. So let's get right into it.
Look, we all know semaglutide 2.4 milligrams has been a total game changer in our practices. The results we saw from the original STEP program were frankly remarkable. But we also see in the real world that there's a whole spectrum of response. So it really makes you wonder, for those patients who need or, want to achieve even greater weight loss, have we basically hit the ceiling with the current dose?
And that's exactly the clinical question that the STEP-UP trial was designed to answer. Because despite how great 2.4 milligrams is, some individuals just don't quite get to their therapeutic goals. And that creates a very real need for, well, what's next? We need an option for treatment intensification.
So, here's the plan for our explainer. We're going to go inside the STEP-UP trial design, then we'll really unpack all that juicy efficacy data. After that, we'll look at safety and tolerability, and finally, wrap it all up with what this could actually mean for our practice.
Okay, first up, let's get into the nuts and bolts of the trial itself. Because to really trust the results, to really feel confident in the data, we have to understand exactly how they got there.
So what exactly was STEP-UP? Well, it was a seriously robust, 72-week Phase 3b superiority trial. And it ticks all the right boxes: randomized, double-blind, multinational, and, this is super important, it was both placebo and active-controlled. That means this new dose wasn't just compared against nothing, it was put head-to-head with the current standard of care. And who are they studying? Well, the trial enrolled adults with a BMI of 30 or higher who had already tried to lose weight through diet without the success they wanted. And, crucially for our discussion today, it specifically excluded anyone with type 2 diabetes, which they defined as having an HbA1c below 6.5%. This schematic really lays out the trial structure beautifully. You can see that 5-to-1-to-1 randomization, which means most of the nearly 1,400 participants were in that higher 7.2 milligram dose group. The design also had a 20-week dose escalation period, which is absolutely key for tolerability, right? Before hitting a maintenance phase all the way out to 72 weeks. And of course, lifestyle intervention was the foundation for everyone across all three groups.
And if you look at the baseline characteristics, the groups were incredibly well matched. The average participant was about 47 years old, with a mean body weight of 113 kilos, that's roughly 249 pounds, and a mean BMI just under 40. I mean, this is exactly the patient population we see walking into our clinics every single day.
All right, let's get to the part I know you've been waiting for, the efficacy data. So the big question is, how did this higher dose actually do?
The headline number is, well, it's pretty staggering. Using the trial product estimate, which basically shows what happens if patients stick with the treatment, the mean body weight reduction with semaglutide 7.2 milligrams was 20.7%. Just let that sink in for a second. 20.7%.
And this graph tells the story perfectly over those 72 weeks. Just look at that clear dose-dependent separation between the lines. It starts early and it just keeps getting wider. The 7.2 milligram arm, that's the blue line, it just drops to a much lower point than both the standard dose and, of course, the placebo. So here's the head-to-head comparison, and this is really the crucial takeaway. The 2.4 milligram dose delivered a fantastic 17.5% weight loss, but stepping up to 7.2 milligrams gave patients an additional 3.2 percentage points of weight reduction. That is both statistically significant and, I think we can all agree, clinically very meaningful. But the average weight loss is only part of the story. Check out the proportion of what we'd call high responders. Over half, more than 50% of patients on the 7.2 milligram dose lost 20% or more of their body weight. And this is even more impressive. 1 out of every 3 patients achieved a weight loss of 25% or more. That is literally double the rate we saw with the 2.4 milligram dose. Now that level of weight loss has some profound effects on anthropometrics. By the end of the trial, an amazing 43% of people in the 7.2 milligram group had achieved a BMI below 30. Think about that. They effectively moved out of the clinical category of obesity altogether. And more than a quarter got their BMI below 27. And it's not just about BMI. We're seeing huge improvements in other markers of cardiometabolic health. Patients on the 7.2 milligram dose saw their waist circumference shrink by an average of 17.5 centimeters. That's almost 7 inches. a really powerful sign of reduced visceral fat.
Okay, so the efficacy is clearly impressive, but of course that's only half of the equation, right? It has to be balanced with safety and tolerability. So what was the patient experience actually like on this higher dose?
So looking at the overall adverse events, the rates were pretty high across all groups, which, isn't too surprising in a long trial. Gastrointestinal events were, no shock here, the most common, hitting about 71% of patients in the high-dose group. What's important, though, is that discontinuations due to AE stayed really low, just 5.4% in that 7.2 milligram arm. But I'm sure your eyes are drawn to one number that really jumps off the page: dysesthesia.
But before we dig into that, let's just put the GI side effects in context. The trial investigators summed it up really well. They said, the most common adverse events were gastrointestinal, and the vast majority were mild to moderate and diminished over time, consistent with the GLP-1 receptor agonist class. So basically what we've come to expect.
Okay, now let's talk about that standout finding, dysesthesia. This was reported in almost 23% of patients on the 7.2 milligram dose. Compare that to just 6% on the standard dose and basically 0 on placebo. This is a very clear dose-dependent signal, and it's a key safety finding that's different about this dose.
So what does this actually mean for our patients? Well, dysesthesia in the trial included symptoms like paresthesia, tingling, a burning sensation, or hyperesthesia. The good news is that the vast majority of these events were mild to moderate. And critically, almost 86% of patients who experienced it actually recovered while they were still on the treatment, and it only led to someone permanently stopping the drug in less than 2% of the cases. That is crucial context for counseling our patients.
Okay, so let's try to pull all of this together. We have this really powerful new evidence, so how do we start thinking about applying it in our own clinical practice?
Ultimately it all comes down to that clinical calculus, doesn't it? That balance of benefit versus risk. On the benefit side, you've got this absolutely superior weight loss, the potential for 1 in 3 of your patients to lose over a quarter of their body weight, and more people actually reversing their diagnosis of obesity. But on the risk side, you do have a higher rate of GI side effects and this notable incidence of dysesthesia that we absolutely have to monitor and discuss with our patients up front.
So, to wrap up the trial data, the official conclusions were pretty straightforward. 1. Semaglutide 7.2 milligrams was superior for weight loss, period. 2. It showed a favorable benefit-risk profile for this specific population. And 3, the safety profile was what we'd expect from the GLP-1 class, but with those 2 key exceptions we've talked about: the higher rates of GI events and that dysesthesia signal.
And this really leaves us with a fascinating question to chew on. For decades, right, a 5 to 10% weight loss was the gold standard, the benchmark for success with an obesity medication. But now, with data showing an average loss of over 20% and a third of patients hitting over 25%, how does that change our goals? How does it change the conversation we have with our patients about what's actually possible? It really does feel like it's setting a whole new bar for what treatment success can look like.